All right, let's talk about pulmonary circulation. If you're getting ready for your final anesthesia exams, you know this topic is a big deal. We're going to cut right to the chase and focus on the high-yield concepts that you absolutely, positively have to know.
So, let's start with the big picture. The one question that really ties all of this physiology back to what you actually do in the operating room. Everything we're about to cover is designed to help you answer this one critical question.
And to do that, we're going to break it down into these 6 key parts. We'll start with the real basics of how oxygen gets around, and then build all the way up to how our anesthetics directly impact the lungs.
Okay, let's get into it. Before we can really get a handle on what goes wrong under anesthesia, we've got to have a rock-solid foundation in how oxygen is supposed to get from the lungs to the tissues in the first place.
So, oxygen travels in 2 main ways. The vast majority, we're talking like 98%, it just grabs onto hemoglobin for a ride. Then you've got this tiny little fraction, just 2%, that dissolves right into the plasma. Now you might think, 2%, who cares? But that little bit is super important, because it's what creates the partial pressure that actually pushes oxygen into the cells.
Okay, this equation right here, this is non-negotiable for your exam. You just have to know it cold. What's so great about it is that it pulls together both ways oxygen travels, the part bound to hemoglobin and the part that's dissolved, to give you the total oxygen content of the blood.
So, if you plug in the numbers for your typical healthy patient, what do you get? Well, the arterial oxygen content, or CaO2, comes out to about 19.8 milliliters for every 100 mils of blood. Just think of that as the full tank of oxygen leaving the lungs ready to go.
And then, after that blood has made its trip around the body and dropped off oxygen to the tissues, what's left? Well, on the venous side, that number drops to 15.2. And that gap, that difference right there, that's the oxygen that actually got used. That's the whole point of this system.
Okay, so that leads us perfectly into our next big idea, the oxygen cascade. This is basically the story of oxygen's epic journey, from the outside air all the way into the cell.
So what is the oxygen cascade? It's really just a way of thinking about the step-by-step drop in oxygen pressure. It's this downhill journey from the air we breathe all the way down to the mitochondria, which, is where the magic happens.
And you can see how the pressure just keeps dropping at each stage, right? It starts out super high in the atmosphere, then bam, it drops in the trachea because of the humidity, then it drops again in the alveoli when it mixes with CO2, all the way down to its final stop.
And this picture really drives it home. The big takeaway, the thing to really remember, is that when something goes wrong, whether it's hypoventilation or a VQ mismatch, it's like you're making one of these steps in the staircase even steeper. That makes the whole trip down less efficient and puts that final oxygen delivery at risk.
All right, now we get to the absolute heart of pulmonary physiology. We're talking about matching ventilation, that's the air coming in, with perfusion, the blood flowing past. It's simple, right? For gas exchange to work, you need the air and the blood to meet up at the same place at the same time.
So the trouble starts when that match is off. You've got 2 main extremes to worry about. On one side, you have shunt. The easiest way to think about this is blood flowing past alveoli that aren't getting any air. Classic atelectasis. That's a low V/Q. Then, on the other extreme, you have dead space. This is the opposite problem. Plenty of air, but no blood flow. The classic example? A big old pulmonary embolism. That's a high V/Q state. So the lung knows this can happen, right? It's not just going to sit there and let VQ mismatch ruin the party. It has this incredibly smart built-in reflex to try and fix the problem on its own. And that reflex is called hypoxic pulmonary vasoconstriction, or HPV for short. Here's how it works. When a part of the lung isn't getting enough oxygen, the little arteries feeding that area automatically clamp down. How cool is that? It literally diverts blood away from the crappy, poorly ventilated parts of the lung and sends it over to the healthy parts that are working well. It's the lung's own little optimization system. Now, this response can actually be beefed up by a few things. For instance, if a patient is acidotic or has high CO2 levels, that'll actually enhance the HPV response, making it even stronger.
But, and this is the absolute clinical punchline for us in anesthesia, a lot of things can weaken this protective reflex. And the number one culprit, the one you absolutely have to remember for your exams and for Monday morning in the OR, is that our volatile anesthetic agents directly shut down HPV.
Okay, so this is where it all comes together. We're going to connect all these dots, the physiology, the reflexes, directly to what we see and what we cause when a patient is under general anesthesia. This is the big payoff.
So, the first big hit, general anesthesia always reduces a patient's functional residual capacity, or FRC. You absolutely have to think of FRC as the patient's personal oxygen tank. It's that buffer they have during apnea, like right after you push the propofol, and the first thing we do is shrink that tank.
And if that wasn't bad enough, just laying the patient flat on their back can knock out another liter of FRC, a whole liter. This massive drop in lung volume is just asking for atelectasis, the collapse of all those tiny airways and alveoli, creating a pretty significant shunt.
So you've got this atelectasis, this shunt starting to form. And what do? We turn on the gas. And with every single breath of sevoflurane or desflurane, we are actively taking away the lung's main defense mechanism by blunting HPV. We're forcing blood to keep flowing to those collapsed, useless parts of the lung. We're actively making the shunt worse.
So you see the perfect storm we're creating here? It's a double whammy. We shrink the patient's oxygen reserve by crushing their FRC, and at the exact same time, we knock out their ability to compensate for it by inhibiting HPV. It's no wonder the result is more VQ mismatch and a huge risk for hypoxemia in the OR.
Okay, let's quickly wrap things up and talk about where this info comes from and how you can dig a little deeper.
So, the key concepts we've covered in this high-yield review were pulled from Respiratory Physiology copy.pdf. For your exam prep, I really can't recommend enough digging into a dedicated physiology text like this one. It'll really solidify these ideas for you.
And that leaves us with one final, really important question for you to think about. This stuff isn't just abstract theory for an exam, right? Now that you know exactly how we mess with the lung's natural defenses, how is that going to change how you proactively manage your very next patient's oxygenation? Thanks for tuning in.